I am Dr. Tutan, interventional cardiologist from India. I will be presenting my case exploring a therapeutic dilemma, a case study of bilateral renal artery stenosis induced by aortoarteritis manifesting as hypertensive emergency. So as we know, especially in the younger people, renal artery stenosis is one of the probable diagnoses for acute onset hypertension. This young lady, she presented to our hospital. She is only 23 years old. She presented with severe hypertension and altered sensorium. The hypertension was found to be refractory to 4 antihypertensives, including the IV infusions. Now, thinking about what could be the cause having such refractory hypertension, such as we went for extensive workup in CT angiography. We found that this young lady, she has bilateral renal artery stenosis in the ostium. Along with that, she had signs of aortoarteritis, and there was severe abdominal aortic narrowing near the origin of renal artery. So this is the renal angiogram. You can see the left renal artery and the right renal artery is almost 95 to 99% stenosis. Even doing the angiogram was little bit difficult because she had feeble pulse almost in every part of the body. It was a very feeble radial brachial pulse also, even in the femoral. So next, when I took the case for intervention, my initial plan was to do a balloon dilatation, as it is well mentioned in the literature, to establish the renal flow, which will give the maximum benefit to the patient. So initially my plan was balloon angioplasty. If it was not giving the adequate result, desired result, then I am going to stent it also. So these are my hardwares for the cases. Initially, I thought of going radial access, but just one day prior, I have done angiography of both coronary and renal with much difficulty. Next day, I couldn't get a pulse for puncture. Right, then I chose right femoral. Unfortunately, I could puncture, but there was very minimal flow. So I was not very sure where it was going. Even ultrasound guided, I tried, but the artery was full of thrombus and it was severely narrowed. In the left femoral artery, I managed to get an access. However, just for putting the sheath, the traditional wire we used was not able to negotiate further. So even for putting the sheath also, I had to use a coronary wire. With the help of coronary wire, I finally could put a renal sheath. Then through that, I continued my intervention. You can see this is the left renal artery. I wired it with a coronary wire. Then what I did, I dilated it with a 5x10 coronary balloon. After dilating with the coronary balloon also, there was no satisfactory flow and there was no clinical improvement also not visible to me, neither clinically nor angiographically. Then what I did, then I stented it. You can see the aorta, you can see the severely narrowed aorta. Severely narrowed aorta near the origin of renal artery. So it was little bit difficult even for negotiating the stent also after so much dilatation. After putting the stent, you can see it is a very far, it is a fibrotic lesion. Even after post dilatation, you can see the wasting, that dog bone effect, typical what we get, what we usually see in the highly calcified lesion and all in case of coronary, but here in this renal artery is so tight, it's so fibrotic that even after stenting we can see it. But however, I could get a good result. This is the left renal artery. Next, I started with the right. You can see again the right renal artery is also around 95 to 99% stenosis. And there are hardly any place for anything to go. It is so much narrowed. You can see. Just after putting the stent in the left renal artery, I had only place for putting the catheter in the whole aorta. So it was that much narrowed. So the same way, I have stented the right renal artery also, which was followed by post dilatation. So after stenting, you can see as I was doing the ostial stenting, so I had kept one wire in the aorta itself so that my guide doesn't enter into the renal artery. So there will less chance of my stent getting migrated. After post dilatation, you can see this is the right and left. You can see a decent result. But what was more important than the angiographic result was the clinical result. Even on the table, her blood pressure, which was around 240 to 250 by 110, it came down to 150 by 100 within an hour. Then after successfully completing the procedure, her sensorium improved in the next 24 hours. She became symptom-free almost. There was no headache and there was a sense of well-being. She was discharged 48 hours after observation with single antihypertensive and immunomodulators for aortoarteritis. This young girl is still under my follow-up for last 8 months. She's doing quite well. She's currently taking telmisartan 40 mg and the other immunomodulators for her aortoarteritis. So the discussion. So for young patients, especially the young patient, though we know even RAS, renal artery stenosis, is also very common in elderly. However, in young patient, it poses a diagnostic challenges. We must keep in mind while working up a patient, young hypertensive, that renal artery stenosis is one of the likely causes, which can sometimes present very erratically erratically, just like in this case, as hypertensive emergency. Second thing, I have done some more few cases also, aortoarteritis induced renal artery angioplasty, though the presentations were different in those cases. So my point is, in our part of the country, aortoarteritis induced renal artery stenosis is much more common. The efficacy of endovascular intervention in restoring renal perfusion and the normalized blood pressure is also important. So coming to the conclusion, aortoarteritis induced bilateral renal artery stenosis can present as hypertensive emergency. Prompt diagnosis and intervention is not only necessary but also rewarding, both for the patient as well as for the doctor. Endovascular intervention in achieving the favorable outcome in patients with refractory hypertension is always to be kept in mind. So I would finish well before on time. Thank you.